Sounds good. All right, well, good morning. I'm Andrew Marshall, the Associate Director of the Office of Ideas, which stands for Inclusion, Diversity, Equity, and Social Justice. This was supposed to be a co-presentation with one of my mentors and colleagues, Dr. Landry. I am here filling in for him as he had an emergency. But today we're going to talk a little bit about high-tech and low-tech solutions for advancing health equity. I'm an emergency medicine doc, but I'm also a clinical informaticist and kind of specialized in the high-tech solutions. That being said, we want to give you a broad overview of kind of what those solutions are and some examples of how they've been implemented. I'm going to just forewarn you, this is a 20-minute talk. Each of these slides itself probably could be 20 minutes. So we will just give a very high overview. So just some quick disclosures. The digital whiteboard project that we are going to talk about at some point during this project the research was funded by E Corporation. I also consult for a couple of telehealth companies and an EHR company. All right, so let's start with a couple definitions. So when I think about high tech, I think about something that utilizes modern or futuristic technology. And when I say a high barrier to use, I mean that it's a high barrier to use either for the patient themselves. It means that they actually have to have a device, or they have to have some monetary access, or a high barrier to use for the hospital, because these are things that are not traditionally implemented. When I say low tech, I mean something that utilizes little to no technology. Some of these low tech solutions will utilize little technology, but generally technology that everybody has access to. Relies on kind of traditional means of addressing inequities. And so I consider these low barrier to use. And so we start by defining health equity. And if you're here, you probably already know what health equity is, but health equity is the concept that everybody kind of gets what they need to achieve the same health outcomes. We won't dwell on that too much, but we'll start with our first low-tech solution. And I consider this section human resources. And so a friend of mine aptly calls these resource connoisseurs. And so your resource connoisseurs would be your social workers, your case management, your housing navigators, your CHWs, which I highlighted here, the people that can really interface with your patients in your emergency department to try to help them bridge the gap, with any social determinants that they have. We talk about high tech and low tech, but human resources are, expensive as well, right? You think of the high tech solutions as being expensive, but you've got to hire people, you've got to train them, you've got to get them networked into the resources that you want to deliver. And I think that, we often forget and take for granted that we have such great resources to connect people. Community outreach, community-centered outreach, and I want to give you guys a really good example of this. So in Boston, we have the Center for Community Wellness at Sportsman's Tennis and Enrichment Center, and I'm a big tennis player, so I'm always there. But the way this place is kind of utilized is it's a trusted facility. It's Black-owned in Boston, and it is in a predominantly African-American part of town. And it's really trusted by the people that live there. It's been there since the 70s. It's provided support for the community that it's in. And the way this is kind of like utilized is that the Brigham actually goes there, provides free dinners, gives health talks. And during the pandemic, when all the kind of sports activities, all the community activities kind of shut down, it was actually a big place where, we used to get ideas out about the vaccine. And when we used it to vaccinate patients, we used it to do education sessions, because these places are ultimately connected with the community and can help address the gaps that we have in health literacy. And so I consider these low-tech solutions, but you can see that on the other side of them, if you're using people or if you're using community outreach centers, you may need to use technology like Zoom to reach people. You may also, your housing navigators, your social workers, your case managers also need to use technology basically to link people into the resources that they need. But these are solutions that the patients themselves don't have to have high access to tech. So let's talk about high tech. Bridging the digital divide. So you guys probably already aware, but the digital divide just basically says that there are people that don't have access to all of the resources that we kind of take for granted on our day-to-day. And this was really exacerbated by COVID, when we realized that we were switching heavily to telemedicine. Students were switching heavily to online education, but not everybody has the broadband internet access or the devices to basically do this. And if you do have the broadband internet access and you do have the devices, sometimes you don't always have the tech literacy to utilize these devices. So those are just some statistics on the digital divide, but I want to talk to you about how we can help our patients get internet access. Right? So I think this is a high-tech solution. And so one of the programs that's running out of MGH, Center for a Healthier Democracy, is called Link Health. And it deals with helping people get internet access. And basically what they're doing is they're writing internet prescriptions that are centered around using the Affordable Connectivity Program, which is a Biden administration program that allows people to get up to $75 of internet for a fraction of the price. And so this program is basically introducing patients that might need telehealth follow-up visits to the ACP. They're visiting these community health centers, and they're using this framework of getting out the word that is kind of like the same as the Get Out the Vote framework. And it's been really effective, and they're starting to partner with actual internet companies, because the internet companies would actually be interested in getting more people to use their software, knowing that it's going to be subsidized. Not software, but their service, knowing that it's going to be subsidized by the government. So this is a great way, if you guys have the opportunity, to get this into your emergency department, to sign patients up to get internet access. Then we talk about tech literacy. Another program that we partner with is Tech Goes Home, and there are many prototype programs like this. I'm only going to talk about Tech Goes Home because it was specifically that we worked with them. But Tech Goes Home, basically we launched a pilot during the pandemic where we targeted non-English speaking elderly patients that we wanted to get more up to date on their tech literacy. And so basically it's 15 hours of classes plus a device that was provided. And they come to either, once they're trained on Zoom, they come to either the Zoom classes or we're looking to pivot to doing this on inpatients while they're actually still in the hospital to do some training for them before they leave. So when they leave, they can feel comfortable getting their follow-up visits via telehealth if they need it. And so Tech Goes Home has this whole program where they teach you to use your email, they teach you to use your PowerPoint, they teach you to use all your basic things that you would need to be a successful internet user. And we know that there are many disparities when we think about age and when we think about language barriers to using tech. And then we want to propose device agnostic solutions. And so this is a digital whiteboard that me and the team at the Brigham built and actually put in our rooms. And it's a very interesting project, right? Because when we say device agnostic, it's actually physically on a device, but patients don't have to bring their own device. They can view this information when they come to the emergency department. So this is a low barrier to entry because basically they don't need a device to access their own health information, right? We know that the 21st Century Cures Act has made it possible for patients to access their information almost instantaneously, but if you don't have a device, you are at a severe disadvantage. And so we basically did a pilot of these digital whiteboards. We provided basic information about the ED stay, including the team name, the labs where you were at in your visit, whether or not you were allowed to eat food or not, whether you'd been admitted, and we checked some the things you would expect. We checked for patient satisfaction using our kind of standard ED patient satisfaction score, and we checked for net proponent score, and we actually found significant increases in those in patients that had viewed the whiteboards. And there's previous research that shows that just good communication with your ED patients can improve their engagement, improve their sense of where they are in their stay, and create better outcomes. So let's talk about low tech again. So I'm going to talk about agile hospital operations. This is all leaning a little techie, because of my background. But agile operations, the concept of agile is basically it's an iterative cycle where you are kind of getting feedback from patients. you are doing an implementation, making a quick change, and measuring it, and then coming back and getting more feedback from the patients. And so I want to emphasize the step 3, which is collaborative design and development, where you are reaching out to your patient population, you're asking them what they need. For example, if you feel like patients are not getting their pain addressed correctly, you're going to want to look at the data on that. If you feel like there is an adverse event happening when you're admitting patients to certain service, you're going to want to look at the data. You're going to say, how can we make an actionable change, and then make that change, and then try to measure it afterwards. This is the whole concept of Agile. And so this is a low-tech solution because this is more of a people thing, right? How do you move the people around in your emergency department or your hospital to really be able to collect that data, to analyze it, and get the feedback from the patients that can help you make the changes. And so I wanted to give you a concrete example of this. Many of you may remember the study from the Brigham and Women's Hospital that said basically that cardiology patients, we were kind of discriminating against some of our cardiology patients, and that may have to do with certain populations having better access to primary cardiologists. And so what we did, because we were noticing the disparity in cardiology heart failure admissions, more patients of color were going to medicine than they were to the actual cardiology service. What we did was we implemented a change, and that change basically involved creating a general cardiology team called the B team, and you can see how we made that change in Epic, and creating a clinical decision support that said, when you're admitting a patient that is suspected to have heart failure to the hospital, that you should consider admitting them to a general cardiology team, even if they don't have a specific cardiologist. And in that way, we were able to take that disparity we were creating, kind of do some restorative justice and correct the problem. And that was, I consider this low tech because this is a hospital intervention. This is a people intervention. We had to build the teams. We had to implement the new workflows, even though some of this had to be built in the electronic health record. Applications of artificial intelligence. I think everybody's talking about AI today. And everybody thinks that AI is kind of the future. I want to say that it's the future, but it's also kind of the present. This is a little bit outdated because this came out in 2021, but I want to let you know that software is a medical device. AI algorithms, more than 500 have been approved by the FDA as of yesterday when I checked. So I think it's like 524. So these are already being used. And so I want to give you a kind of concrete example of how you can use AI to improve health equity. And so we all know that people perceive pain differently, and we know that the way that we choose patients for interventions sometimes hasn't changed in years. And so in orthopedics, there is a KLG score, and something German I can't really pronounce, but there's a KLG score that basically looks at radiographic evidence and physical exam evidence to try to decide if the patient is a good candidate for a knee operation. It turns out that African American patients specifically have pain that's kind of out of proportion for this KLG score, and often do not get the intervention that they need with this traditional score. And it makes sense because this score was developed in the UK, and it was developed many, many years ago, many years before I was born. And so it probably does not take into account anatomical differences. So one way to address this, Ziad Obermeyer and team kind of looked at a way to objectively classify radiographic findings using artificial intelligence. And they came up with another score called ALGP, which basically highlights areas and that may be problematic, may be related to additional pain in certain populations, and was able to reduce the disparity in the number of patients that were going to be selected to get an operation to improve their knee pain. We can talk briefly about improving triage. I really like this paper that came out, I think, probably last week in JAMA Network, but basically looked at the distribution of emergency severity index and mistriage. And we can see that if you look at the paper, that there were certain populations that were mistriaged, under-triaged, over-triaged, a little bit more than their other counterparts. And An opportunity here, and there are many companies that do this, is basically to implement an algorithm that helps with clinical decision support and helps your nurses more accurately do triage. It is kind of hard when you do triage all day out in the front, and you may get a little bit subjective just based on why you think that patient may be coming to the ED. If it's somebody that comes often, that's somebody that's like homeless, and an algorithm may provide a little objectivity that helps you. Clinical decision support may help you better triage the patients and reduce health disparities. So low tech, I want to touch on this a little bit. Information accessibility. And so when we talk about health literacy, we have a profound change in our ability to access health information. And so, there have been a few studies that have come out now on using TikTok, and this one that we have here specifically is about using TikTok to get information about COPD. And you can see that they use the Discern score. Discern score basically helps people evaluate if the information is clear, if it's helpful, and then they looked at the different sources from which this information came and ranked all of these videos. And it turns out that there's videos that are made by corporations, there's videos made by healthcare providers, there's videos made by everyday people that are not in healthcare, and they all contain very valuable information, and they're able to transmit that information a lot faster than we were able to transmit this information via traditional methods in the past. So while this is obviously you have to have a device, you have to have connection to the internet. I think this is a low-tech solution because many younger people who have these things are inadvertently kind of stumbling on this information and using this information to inform their healthcare decisions. And I think this is a really valuable way and a thing that we've got to tap into in the future when we think about promoting health equity, getting the message out on certain health initiatives for our younger populations. And so I'm going to leave you with this, a framework for implementing innovative solutions. So I want to give you 6 guiding principles of equitable tech implementation, and I think throughout the other things you may see some of these themes weave into what I've already said. So inclusivity, transparency, bias mitigation, privacy and security, collaborative design, evaluation, assessment, and course correction. And so just to get into a little bit more detail, when we talk about inclusivity, we want to create innovative solutions, whether those are tech solutions or operational solutions that do not take into account education level. So you need to make sure that everybody, low reading level, lots of things in different languages. You don't want it to have a too high barrier for people who have poor tech literacy. You don't want to make people buy devices, right? So you need to take into account socioeconomic status, disability, and language. So all of these things you need to take into account when you're thinking about inclusivity. Transparency, you need to have clear clinical criteria. It needs to not just be explainable, but it needs to be interpretable by the physician, right? So sometimes you can see the result of an algorithm and then go back and kind of like, yeah, this is how we think this algorithm kind of came up with this decision. And that would be explainable, but we want it to actually be interpretable, where you can see the wheels turning inside the algorithm and say, no, I actually disagree with that as a clinician, and help you change your decision. We want to talk about bias mitigation. We talked about triage earlier, where you can have some human bias that causes people to be up triage and down triage. But we want to make sure that if we are going to create algorithms or use high-tech solutions that use previous data, that we are not baking that bias back in, and that we are also, again, collecting data and making sure that we are reducing human bias, not just perpetuating it. Privacy and security, I think we think about this a lot in healthcare. You want to make sure that your data is secure. You want to make sure that your patients are confident that when they're using a device or a tech solution to address their healthcare needs, that their data is secure, and that the data use agreements are very clear, like who owns the data, et cetera. Collaborative design. So when you're designing these things, we can go back to the agile methodology we talked about earlier. Really take a step, get your users involved early in a diverse user group, and make sure that they are engaged in helping you develop your product. And then evaluation, assessment, and course correction, I think, is the most important thing. Even if when you roll something out, have a plan to move swiftly to adjust it to address any inequities that may arise when you create it. So that means that you've got to be constantly, looking at the data, looking at the different demographics, making sure that your patients are getting equal access to the intervention that you're making. And then you have to be able to, quote unquote, fail fast. You don't want your intervention necessarily to fail, but you definitely need to, if it's not working, be able to pivot. Like, for example, when we talked about cardiology, be able to pivot and make a way for people to get better access to these things. And I want to give a special thanks to Tala Brown, who's at Stanford and also giving a talk right now, for helping me think through some of these health equity solutions as they relate to technology, and that's my contact information. All right. Thank you, guys, and I'll open it for questions. I don't know how much more time I have.
That was really great, and I was just wondering, what's the state at present for bringing this to bringing some of these things to emergency departments, and what you think might be feasible in emergency departments? Because clearly you're aware of a lot of the high-tech and low-tech, I'll just call it products, even though it's not products, in your region, and it probably took a while to find some of those community resources in particular. And are there ways, like what's the state of others finding access to some of these technologies and non-technologies? Yeah, so I mean, I think as far as community resources go, like if you're at a hospital, you exist in a community, and you should have some community connections because the community comes to you. And so it really is just like about making a concerted effort to connect with that community and go out and use those resources that you probably already have. It's essentially, networking, which is why it's part of why we're at SAEM, to network. But you've got to network within your community and find out where the trusted hubs are to kind of get people engaged. Because the trusted hubs might reach people in a way that, maybe your ivory tower institution does not, or your hospital does not. And as far as like the tech solutions, I think all that you kind of have to do is show a return on investment at one institution, and I think that's why we publish research and we try to do these things. Net promoter scores, patient satisfaction, these things are really important when we think about how our patients interact with the emergency department and their likelihood to come back and their actual, healthcare outcomes. So, I think that once the prototypes are done and once we kind of publish them, I think for all these technologies, emergency departments kind of across the U.S. can hopefully start to replicate these things in their own way, in their own system, in their own EHRs, in their own operations, and try to make them come to fruition. Thanks for that question.
Is there any data for the pre and post interventions, like the clinical decision-making tool for the heart failure and the cardiology versus medicine admission?
Yeah, so there is data. I'm not sure that it has been published yet. So I think they're planning to do a follow-up study, but that initial study just came out in 2019, and so I know it's 4 years later at this point, but we went through a whole pandemic, and I think the priorities changed a little bit, but I would expect to see that data coming out soon, and it certainly has been presented internally. I just didn't happen to have it on my slides. But again, like I said, each of these things that I discussed, we could have a 20-minute presentation on any of them. So this is a kind of just like a high-level overview. Thank you, guys.